Health experts are raising concerns over coronavirus testing methods as the total number of cases in the U.S. surpasses 6 million. The New York Times suggests that tests may simply be too sensitive and slow to contain the spread of the virus, diagnosing people who may not be contagious and preventing health officials from finding those who are contagious in time. So, for more on this, let us bring in New York pediatrician Dr. Dyan Hes. Doctor, every single day, this is why we have a doctor on every day to talk about this. Every day there is just sort of more confusing information. So now we're hearing about this possibility that, the tests are diagnosing large numbers of people who are carrying an insignificant amount of the virus, and so maybe they're not actually contagious. Should we be testing less? Should we perhaps not be testing people who know they've been exposed, but they're not showing any symptoms like the CDC had suggested about a week ago?
I don't agree not to test. I do believe that we still need a good sense of how prevalent this is in the community. So I believe that the more testing, the better. I do agree that we're probably going to get positives of people who might have had it in April or May, and they're still shedding some of the RNA fragments in their nasopharynx. But I think it's better to err on the side of caution that we're catching them and like maybe mislabeling them as contagious until we know more about how to manage this virus. Because what we do know is, when you're isolated and not sharing communal areas, like this is why we're seeing the college outbreaks, like they're in a communal kitchen or a bathroom. That's when the outbreaks are happening. So in order to prevent those, like at this point, we can't tell. We don't have when you get a positive result, you don't get the level of how positive you are. So I think to err on the side of caution, we do have to isolate at this point. And maybe in a year from now, it'll be we'll have a different test and it'll be a game changer. And it'll say, oh, you're like 6 weeks out. You're not contagious anymore. Your viral fragments are very small. You can go back to work, back to school. But at this point, when we don't know how to manage this and what those levels are, I think we have to err on the side of caution.
And I think also what we're dealing, and so you point out that if you test positive, you don't know if you got a little or a lot of the virus in your system. You just know perhaps maybe you have no symptoms. So isolation is what we are doing now. We are washing our hands, right. We are wearing masks, and we are isolating if you test positive. But there are so many different types of tests out there. I just learned a friend of mine who is still kind of traveling here and there, but he's very concerned about the coronavirus, went for, I think, 3 tests, plus he got an antibody test. They're tests that give you the results in 15 minutes. Sometimes you got to wait 2 weeks. Can you just kind of give us a lay of the land? Like what are the differences with some of these tests?
So the rapid test there's some that are antigen, which is testing for the antigen that you have that coronavirus antigen in your blood, which means in your nasopharynx in your body, which means that you actually have that coronavirus. But those tests are not that specific. That's the problem. So they're very rapid. They're a good screener. So if you have a positive antigen test, then you really should get a PCR test, which looks for the DNA. So like if you think about a strep test, the rapid strep test is about 95% sensitive, but if it's negative, your doctor still sends a throat culture. So this is kind of, we don't have a culture for the viral. We don't grow it on a viral medium. We look for with the PCR, we look for the RNA fragments. So the antigen is a great screener, but it's not 100%. Abbott makes a molecular test, which is very sensitive, they say. So if you get a positive on the Abbott, you don't have to do a repeat PCR test. Now Abbott is coming out with a fast test that's going to be $5, 15 minutes. But what we heard from the reps is that all these kits are going to go to schools K through 12, so they can test kids rapidly if they think they have it in school. The problem is that as physicians, we can't get these tests, so we're grabbing at straws. Like if a rep calls me and says, "Listen, I can get you 100 BD Veritor tests," which is an antigen test, I'm going to take it because I have nothing right now. So I tried to get that, but you know what? Now they all were rerouted to nursing homes. So it's like the science is trying to catch up with the virus, and the medical community is trying to get these tools, which are not that accessible right now, and they cost a fortune. So there's this lag time. We're trying to make conclusions from something that's only been tested for a few weeks to months.
So here's what we know. We know that testing is a very valuable tool, an essential tool when it comes to getting this virus, getting a handle on this virus. We know that there are different types of tests that work in sort of different ways and test different things. We know that your viral load, and I may not be using the right phrase, there could be a range, and the FDA hasn't sort of specifically sort of indicated how much virus makes you positive, like what really means a positive test. So I want to ask your sort of medical opinion. You know, how do we fix this mess? How do we streamline it? How do we develop an effective process so we can identify infected patients who may indeed infect others?
It's really time, because like now, one study came out and said that children have more viral load than adults, but yet we just saw that study that you actually sent me that in daycares in LA, no children tested positive out of the 7,000 children, but some of the workers were positive. So masks are working. So why are these kids? They're not spreading it to each other clearly in that daycare in LA where the rates might have been high. There's just too many unknowns right now. I did forget to mention that the saliva test is out as well. And the saliva test is a PCR test, and it's actually quite accurate. And a study came out in the New England Journal of Medicine this week that said the saliva test was actually better than the nasopharyngeal test. Now, that usually takes 3 milliliters of spit. That is very hard for a child to produce. Like an adult can do it, but to tell like a 3-year-old or a 2-year-old, it's just a matter of time. We are trying, like we are chasing our tails right now. We're all trying to get data and look at it and analyze it. But remember, the kids haven't been in contact, and now they're going to go back to schools in a lot of places. So we're going to get a whole lot more data very soon that we're going to have to plow through. I mean, we have data sets like NHANES that we go through all the time for cholesterol, high blood pressure, diabetes, and we still haven't gotten to the bottom of it after 20 years. So we're trying to figure out this virus in, 6 months.
So you mentioned this sort of unique situation with daycares in California where, kids did not test positive, but some teachers did. The American Academy of Pediatrics says that cases, hospitalizations, and even deaths are rising fast among children and teenagers. What can you tell us about that?
The numbers are still quite small. So they are rising, but you have to realize that a lot of the states that reopened should not have reopened their schools because the rates were way too high. So, in New York, we're not allowed to open schools if the incidence rate is 3%. But schools like in Florida and Georgia and other states have opened when their rates are in some states were as high as 20%. So you're going to see more cases. It's just inevitable. Those states were not enforcing masking. Some schools are going back to school without enforcing masking. So when there's no national plan, you're going to see more people getting sick. It's just like if you don't get the flu vaccine, you're going to get sick. We know what works. We know masks work, and they have to enforce it. We had camps running here in Long Island where the counselors wore shields. They took the kids in the pool. They wore masks. The kids didn't, and there was no cases of coronavirus. So masks work, and they have to be enforced. And I keep on reading on all of these doctor chat rooms that there are many schools opening where kids are not wearing masks, and some of the teachers are only wearing face shields, and it's not suffice.
Oh my goodness. We've talked about face shields. They're a total waste of time. You have to wear masks if you wear them. Dr. Dyan Hes, thank you so much.
All right. Be well.